Bismillahirrahmanirrahim. I start the CME with the name of Allah, God Almighty, who is very, very kind, merciful, and very helpful. CME update by Mother and Child Survival Group of Pakistan, and CME tips by Dr. Tariq of Skyni Family Emergency Specialist, Gulf KSA, presently a district gynecologist. We are going to review the concepts of infertility when ART was in experimental stage. How infertility was taken, most reliance was then on clinical examination. Infertility, as I told you, that it is a regular practice for trying to conceive a pregnancy for 1 year or more, with regular intervals of meeting. You have to examine male, take detailed history and the examination of the male, that is hypospadias and phimosis, hypospadias, and another congenital abnormalities, varicocele, and any testicular problems. And for the same is for the female, abnormalities of the cervix, abnormalities of the uterus, congenital abnormalities also, as well as polyps and the retroversion, abnormalities of the tube, and that can be blockage, salpingitis, or pyosulfings, or abnormality or tubal blockage, abnormalities of the ovaries, irregular menstruation, ovulation not at regular times or irregularly intervals with infrequent menstruation. So abnormalities of the cervical secretions, and the history asked from the female includes the age, time of marriage, the frequency of the coitus, as well as any time and duration of marriage, and the frequency of the coitus, that is most important, any abdominal operation, lifestyle, menstruation, contraceptives history, smears history, and all these to be judged. Most important is the menstrual history, regular, irregular, or basal body temperature, and pain at ovulation, and any abdominal operation or frequency of the coitus, and the discharge, cervical secretions as well. Then comes the abnormalities of the congenital abnormalities of the uterus, of the vagina, of the tubes, abnormalities, the blockage of the tubes, abnormalities of the ovum, menstrual cycle, and all these has to be taken into account. The husband history has to be hypospadias, varicocele, testicular, any hydrocele, varicocele, any injury to the testes, and also trauma, and any history of hypospadias and testicular abnormalities. Lifestyle of the, so both they should come to you for advice. So detailed history from both, and the husband and the wife be taken in the light of previous tips mentioned. And then there should not be hurry. They should be counseled that it is a process. They have to be patient, and the investigation, they take time, because these are regular and there has to be repeated, and so that after that the accordingly the treatment will be established and started. And meanwhile, in 25 to 30% of these cases, the patients become pregnant while they are investigating for that. So, for example, in the we will arrange husband semen analysis and hormonal assays of the female, and also for the mm, postcoital test. This was taken before when ART was not there. Now it has replaced all these things in the form of IVF and ICSI. And then we have to see for the female coital difficulties, and for the male premature ejaculation, impotence, and difficulty in performing the act, and azoospermia, or sometimes when there is no azoospermia, the count and the motility matters, especially in the postcoital test. For the female, any hymen has to be removed or set, and or pinhole periodontmy to be done if the perineum is tight, and the pinhole has to be adjusted. And then any septum in the vagina, transverse or longitudinal, be divided and repaired. So then any abnormalities in the cervix, in the pap smear, and the high and low vaginal swabs that has to be taken. In the postcoital test, in this you see a number of immotiles, and that it means that the cervical secretions is hostile to the sperms, so that maybe there is a concept of antibodies. And for a male also, for those antibodies, they have been instructed to use condoms for 2-3 months, so that this autoantibodies concept with the passage of time disappears. Then for the females, as I've told you, the menstrual section is most important in fertility and all this. Menstruation, it should be secretory change. It should be there should be secretory change with evidence of ovulation, and tuberculosis of the genital tract to be excluded. Similarly, for the tube also, tuberculosis of the tube be excluded. And there is infections, or there is there could be self-injostomy when the abdominal end is opened, or there could be isthmus blockage of the isthmus, then tube is redivided and reimplanted into the ureter. And third is this some self-ingolysis, peritubal adhesions. Again, TB has to be ruled out in tubal disease. And then comes the ovaries, abnormalities of the ovaries. We check the ovulation as well as menstrual cycle, and the secretory change is very important. Basal body temperature and all these, still they are this one these days, day 21 progesterone is very important. And so when we are starting this, so we the anxiety and other things must be addressed and counseled, and there is, because of sometimes there is depression as well. So psychosexual counseling, and especially those which have psychosexual behavior problem and sexual problems, so there needs a psychosexual counselor. So with these adjustments, the in the uterus, the fibroids need to be removed, especially submucous fibroids intramural, and the retroverted uterus to be made ventro suspension, and the other things to be corrected. For the ovulation, and we have to LH, FSH, prolactin, and human menopausal gonadotrophins to be checked. And if the prolactin is raised, and rule out the pituitary tumor, if it is normal, then bromocriptine is started, then bromocriptine is continued for 3 to 6 months to lower the pregnant prolactin. And then the ovary side, we have to see the endometriosis, and this is also a very important factor, and also Stein-Leventhal ovarian syndrome, this hypoandrogenism, polycystic ovaries, and atrophic ovaries, cystic ovaries, and all these are related to these. And for this, the test are, you see, hysterosalpingography, cosine hysterosalpingography with the for the tubal patency, and for the biosulfings, and also laparoscopy, the gold standard. It only not confirms the tubal patency, but if a dye test is carried out, then you can easily visualize and also you can see the endometriosis in the pouch of Douglas, and there is endometrioma, and there is cysts as well. And there is peritubal adhesion that has to be lysis, they can be. And for them, then you have to give for if the ovulation is not occurring, and then you have to give anti-estrogen like clomiphene citrate 50 milligram, then increase the dose up till 100 milligram and 200 milligram. Another anti-estrogen, that is tamoxifen, is used 10 milligram BD, or then if in successive cycles this is not helpful, then the dose with clomiphene is abandoned, and tamoxifen is carried out with 10 milligram BD, and in maximum 40 milligram BD can be tried. And then with the if these fails, so then the regulation of menstrual cycle and FSLH, the human menopausal and human FSHLH are needed to regulate the cycle and the ovulation and all these. So all these factors are very important. At that time ART was not there, but that was in an experimental stage. Later it came and it brought the revolution. In the microscopic surgery for fallopian tubes have been very much improved, but the results are still the poor, because if it is even repaired, the tube is repaired, the motile embryo is difficult to travel for him, and there results in ectopic pregnancies. So these all the abnormalities are corrected. As I have told you, that secretory change and evidence of ovulation should be there, and the laparoscope is done in the premenstrual phase of the cycle, and can see